Welcome everybody today. While we just get started, because we know there's a few people, it takes a while for people to join into the meeting. So just before we get started, I'll just do some housekeeping. During the webinar, during the Zoom meeting, you'll notice on your screen that there's a Q&A tab at the bottom of your screen. And there's also a chat. So for those of you who are not familiar with the Q&A, we're going to use that today rather than the chat. If you have any questions, please put them in the Q&A tab because they'll be addressed at the end of our webinar. The chat is really for people to share any informative links if you'd like to do that also during the webinar. So just before I'll hand over to Amanda Ginger. Amanda is our the National Accreditation Manager for Healthscope, but she's also the co-founder of the Quality Manager Network of Australasia. And Amanda is going to do the webinar today and present to the quality managers on the clinical care standard for colonoscopy. So over to you, Amanda.
Thank you very much, and thank you to the Commission and for Jenka for hosting this as well. Before I start, I'd like to acknowledge the traditional owners of the lands upon which we're all meeting today. For me, it's the Yugam people in particular, and from the Kombi Mary clan, as I'm speaking to you from the Gold Coast today. I'd also like to pay my respects to their elders past, present and emerging. And I don't want us to forget either those of us that are coming from the Wiradjuri people from the Kulin Nation, our colleagues that have been, are in Melbourne, I should say, that have been doing it tough. We're all thinking of you. So thank you very much. So the colonoscopy care standard was first released in 2018, and then it was amended this year actually. The update included the addition of a fourth indicator, and that's the sessile serrated adenoma detection. So please join me today while I present to you the colonoscopy care standard as we discuss why, what, when and how. Clinical care standards aim to support the delivery of appropriate evidence-based clinical care and promote shared decision-making between our patients, carers and clinicians. A clinical care standard is a small number of quality statements that describe the clinical care a patient should be offered for a specific clinical condition. The quality statements are then linked to a number of indicators that can be used by our health service organisations to monitor how well they are implementing the care recommended in the clinical care standard. Now, a clinical care standard is different from a clinical practice guideline. The guideline describes all the components of care for managing a clinical condition, whereas a standard is quality statements that address priority needs that need improvement. So why? Well, between 2013 and 2014, over 500,000 colonoscopies were performed in Australia, and the Commission reviewed the location of the patients as well as their socio-economic status. The research revealed that there are lots of differences in the rates of patients being scoped depending on their location and their socio-economic status. So the what? So armed with this data, in 2015, the Commonwealth Government requested development of a safety and quality model for colonoscopy. And in 2018, the colonoscopy standard was launched and published by the Commission. This was then integrated into the second edition of the national standards. This integration was punctuated by an advisory from the Commission. It therefore has to be implemented in all public and private hospitals and day procedure centres nationally. Now, remembering that there are 8 national standards in the second edition of the National Safety and Quality Healthcare Standards, the colonoscopy care standard is assessed mainly in Standard 1, and that is the Clinical Governance Standard. Now, as I mentioned before, the Commission developed an advisory, AS 1812, and the advisory means that it's now mandatory for all assessors that come to your organisation to review compliance to this advisory during accreditation and the review of Standard 1. In addition to this, there's a fact sheet number 11, and this sheet is about clinical care standards. And it's about when organisations implement actions 1.27b, 3.15d and 5.29a. So this is what you need to do in your organisation when you have a clinical care standard. You firstly need to check which of the clinical care standards are relevant to your organisation, considering the services that you provide. Then the service needs to provide clinicians in your organisation access to the relevant standard. You then need to document in policies or protocols which of the quality statements in the standard are the responsibility of your organisation and which indicators are to be monitored by your organisation. All relevant clinicians then need to be provided with these policies or protocols. And finally, of course, the organisation then needs to implement the quality statements and monitor the indicators that are relevant to the service. Note also that the quality statements can be the responsibility of more than one provider. So remember that the clinical care standards have been developed for all key stakeholders, patients, clinicians and organisations. That is to inform the patients about the care they receive, the clinicians about the appropriate care, and finally, to identify systems that the health services need to support and monitor for appropriate care. So here are the quality statements that are in this standard, and we're going to go through each one. And here are the 4 indicators that go with the standard there. So the first quality statement is the initial assessment and referral. The purpose of this statement is to ensure that communication of information from referring clinicians to the colonoscopy clinics or your specialists enables the timely and accurate assessment of patients according to clinical urgency and appropriateness. For health services receiving these patients and referrals, it means that they need to ensure that they have clear referral guidelines available for referring clinicians, identifying the type and format of clinical information that you require. Use of this information will support the provision of services according to the patient's clinical priority. Using agreed standardised templates can assist the communication of this, and they can also be in electronic format. The Commission have developed a referral template that can be developed, that was developed in conjunction with clinical experts. In addition to that, it's been embedded into 5 different GP practice software systems. And there's a little example there, or there's the example of the Commission's referral. And here's what it looks like in 2 of the different GP systems. So the second quality statement is appropriate and timely colonoscopy. The purpose of this statement is to ensure colonoscopy is offered to patients who are most likely to benefit from the procedure and within a time frame concordant with their risk, in a manner consistent with the current national evidence-based guidelines. A patient is offered timely colonoscopy when appropriate for screening, surveillance, or the investigation of signs and symptoms of bowel disease. Decisions are made in the context of the patient's ability to tolerate the bowel prep and their likelihood of the benefit. For health services, they need to ensure that policies and procedures and processes support the timely and appropriate provision of the colonoscopy, and this includes supporting and promoting their clinicians' use of the national evidence-based guidelines, including the Cancer Council Australia's clinical practice guidelines for the prevention, early detection and management of colorectal cancer, as well as the clinical practice guidelines for surveillance colonoscopy. They also need to support and encourage clinician participation in quality improvement and peer review processes like your CRAFT committees. And for health service organisations that receive referrals, they need to reflect guideline recommendations from the Cancer Council Australia in policies and procedures for triaging and scheduling of the appointments. So here is just so you can know what the guidelines look like if you want to Google the guidelines. The third quality statement is informed decision making and consent. And the purpose should be quite clear of this statement. It's to ensure that each patient is provided with adequate information and time to consider the risks and benefits of colonoscopy before providing informed consent and before starting the bowel prep or any other aspect of the procedure. So before starting the bowel prep, a patient receives comprehensive consumer appropriate information about bowel preparation, the colonoscopy, and the sedation or the anaesthesia. They have an opportunity to discuss the reason for the colonoscopy, its benefits, risks, financial costs, and alternatives before they decide if they'd like to proceed. We also need to assess if they've understood the instructions as well. So what does this mean for organisations? Ensure that clear written information is provided to patients or available for patients for all aspects of the colonoscopy for which the health service organisation is responsible, which may include the bowel preparation, the colonoscopy itself, and the associated sedation or anaesthesia. When consent is being obtained, you need to ensure protocols and procedures enable patients to receive adequate information to inform their decision. You need to also ensure that interpreter services are available if required, and a fact sheet describing the informed consent requirements for the colonoscopy care standard is available at the Commission. So here's one of the fact sheets from the Commission, and the most important reminder of this fact sheet to remind us is to make sure that there is written documentation to show that informed consent discussion has occurred between the patient and the qualified clinician prior to the bowel prep if the health service organisation itself is advising on supplying and or providing bowel preparation. So bowel preparation is the fourth statement. And the purpose of this, of course, is to ensure that the patients attend with clear bowel so that they can have a thorough examination. A patient booked in for colonoscopy receives a bowel preparation product and dosing regime individualised to their needs, comorbidities, regular medications, and previous response if they've had a bowel preparation before. The importance of good bowel preparation is discussed with the patient. They need to be provided consumer appropriate instructions on how to use the prep and again confirm their understanding. So for health services, you need to have policies and procedures to ensure this and support patients by enabling them to have access about information about bowel preparation. And for health service organisations with responsibility for providing the bowel prep and advice, you need to provide clear written patient information about the bowel preparation procedure and a telephone number for any inquiries patients may have as the bowel prep proceeds. Ensure again that you've got interpreter services or translated materials, and ensure patient information is consumer approved and periodically reviewed by the clinical staff as well. Now, there's a very good video that's been developed by the Commission to help educate the patients, your patients. So we thought we would play that now for you. So cross all your fingers while we hope this works.
A colonoscopy is an important test that examines your bowel to diagnose bowel disease and cancer, the second most common cancer in Australia. The Australian Commission on Safety and Quality in Healthcare has developed a clinical care standard for colonoscopy. Find out what you need to know when you've been referred for a colonoscopy. You need to know your rights, your choices, and your responsibilities. You have the right to have your bowel examined by a qualified and well-trained person at the right time and in the right way. Know why your doctor wants to examine your bowel. Receive your results with a clear written explanation so you and your GP can understand what happened in the examination, what was found, and what to do next and when. To be informed about all the things you can do to reduce your risk of future bowel disease. You have the choice to go ahead with a procedure now or later, or choose other options with your doctor. Discuss the medicine you can have to relax you. You have the responsibility to always tell your doctor about your health, your lifestyle, and any cancer in your family. Empty your bowel properly. It may not be very pleasant, but if you don't follow the diet guidelines and drink all of the sachets given to you, you may need to have another colonoscopy. Reduce your risk of bowel disease and cancer. Exercise, eat well, and do the poo test regularly.
So I really love that video, because to me it means the more our patients get educated, the more pressure comes on our hospitals to follow the standard as well. So next we talk about sedation, and the purpose of this statement is to ensure safe and appropriate sedation of your patients undergoing colonoscopy. So before colonoscopy, the patient needs to be assessed by an appropriately trained clinician to identify any identified risks, including cardiovascular, respiratory or airway compromise, and then the sedation is planned accordingly. And the risks and benefits of sedation are discussed with the patients. Now, sedation is administered and the patient needs to be monitored throughout the colonoscopy and recovery period in accordance with the ANSA guidelines. For health service organisations, sedation should be provided in accordance with these guidelines, as well as the day procedures. Ensure that systems are in place and that services are adequately resourced to implement these guidelines. Policies should state that pre-sedation assessment is carried out by appropriately trained clinicians in order to identify patients who are not suitable for sedation. And then ensure that clinicians who administer sedation or anaesthesia for colonoscopies are credentialed by the health service organisation and operating within their defined scope of practice, and that they maintain their skills by participating in ongoing professional development and review of performance. So then we move on to the clinicians themselves, and this is quality statement number 6. And the purpose is to ensure all colonoscopies and associated sedation and clinical care are provided by skilled clinicians at a high level of safety and quality. A patient's colonoscopy needs to be performed by a credentialed clinician working within their scope of practice, who meets the requirements of an accepted certification and the recertification process. And sedation or anaesthesia are provided by credentialed clinicians working in with their scope of practice, like we said before. Now, there are 2 fact sheets on the Commission's website that you can give to clinicians if you haven't already. One is on the standard that we're talking about, and the other one describes the certification and recertification process, because I know there's still some issues out there. Certification of training and recertification of ongoing competency in adult colonoscopies are now mandatory for all practitioners working in health service organisations that are assessed to the National Standard 2nd edition. Certification of gastroenterologists, surgeons and general practitioner endoscopists is through the Conjoint Committee for the Recognition of Training in Gastrointestinal Endoscopy. This is a national body which comprises the Gastroenterological Association of Australia, or GESA, and the Royal Australian College of Physicians and the Royal Australian College of Surgeons. It sets the minimum standards that are required for training in adult colonoscopy. There is, however, the experienced practitioner pathway, and that's available for experienced clinicians who were not assessed for certification in the context of their college specialist advanced training program. And that's usually because their training preceded the Conjoint Committee. So the EPP pathway has logbooks, and it requires a minimum of 200 colonoscopy procedures to be logged. These can be retrospective. However, 10% of the logged procedures must be under the direct supervision of a Conjoint Committee recognised person. GESA is the only organisation currently that provides recertification for colonoscopists in Australia, and this program provides for triennial recertification. Now, the 7th statement is the procedure itself, and the purpose is to optimise the detection and management of the disease to minimise adverse outcomes for all patients who undergo colonoscopy, and to ensure the colonoscopy is documented adequately in the patient's health record. The adequacy of bowel preparation, clinical findings, biopsies, polyps removed, therapeutic interventions, and details of any adverse events need to be documented. All polyps removed need to be submitted for histological examination. Health service organisations need to ensure that the number of patients booked on each list enables the colonoscopist to perform a careful and systematic examination of each patient's colon, provide systems that require and support colonoscopists to maintain accurate records of the colonoscopy, including the adequacy of bowel prep, the biopsies taken, the polyps removed and retrieved, all diagnostic and interventional and therapeutic interventions, the duration of the procedure, and the details of any adverse events. Ensure that complications or adverse events of colonoscopy are reported within the health service organisation's incident management system, and it's monitored and reviewed as part of your quality management program. So discharge is the next statement, and this is to ensure that patients recover and are discharged safely with available information about the outcomes of the colonoscopy and arrangements for follow-ups. Following the recovery and before discharge, the patient needs to be advised verbally and in writing about the preliminary outcomes of the colonoscopy, the nature of any therapeutic interventions or adverse events that occurred, when to resume regular activities and medication, and arrangements for what medical follow-up will occur. The patient needs to be discharged into the care of a responsible adult when it's safe to do so. So again, health services need to ensure that they have policies and procedures for monitoring, supervising and discharging patients, and that these align with the current recommendations for post-op care following anaesthesia, for example, ANZA guidelines again. Ensure that these procedures are in place for discharging patients into the care, as we said, of a responsible adult, and that you give patients written instructions. There needs to be a response plan for patients in the event of problems arising post-discharge, and that discharge information includes specific health service contacts, details for after hours. And the final statement is about reporting and follow-up. And the purpose of this statement is to ensure that the results of the colonoscopy are effectively communicated and that patients are offered follow-up treatment or ongoing surveillance in accordance with, again, evidence-based guidelines. The colonoscopist communicates the reason for the colonoscopy, its findings, any histological results and recommendations for follow-up in writing to the patient's general practitioner and any other relevant clinician and the patient, of course. And this is documented in your facilities records. Recommendations for surveillance colonoscopy, if required, should be consistent, again, with national evidence-based guidelines. If more immediate treatment or follow-up is needed, then obviously follow-up arrangements need to be made by the colonoscopist. Health services need to make sure that they've got systems in place for prompt communication and management of the histologically confirmed colorectal cancer or high-risk lesions as appropriate for the type of facility. So the Commission also have templates for reporting, as well as a general practitioner follow-up letter if you would like to use that. Health services are not required to use this, but it's just available to assist if you would like it. Some of the scope companies too have some amazing electronic reports here that put the pictures as well as the follow-up information. Now, direct access colonoscopy. A lot of people working in quality and health administrations have questions regarding direct access colonoscopy. It primarily relates to the removal of the initial specialist consultation. The initial consultation represents a barrier to care that may reduce participation, as patients may find it inconvenient, having difficulty arranging transport or support, and find it a stressful process. Nurse-led telephone triage assessments have been shown to be less costly for the patient and allow specialist time to be redirected to more complex patients. The direct access colonoscopy model of care was developed by the Cancer Institute of New South Wales and references and supports this colonoscopy clinical care standard. So now to the when. When do we need to comply? Well, now, the National Standard Second Edition, launched in January 2018, all facilities need to be able to demonstrate their actions toward implementing all the actions of the colonoscopy clinical care standard relevant to them now. And quickly through the how. So the Commission conducted a pilot against the clinical care standard from May to August last year. 4 pilot sites: Alfred, Werribee Mercy, our Brisbane Private Hospital and Liverpool Day Surgery. Following this, they had a lot of findings and they developed a lot of resources. Sorry, I clicked the wrong button. A lot of resources to assist organisations after that. Here's a list of them now. Resources are available on the Commission website. And just to remind you again that some of the additional resources include a clinician fact sheet, a consumer fact sheet, colonoscopy poster, training videos, templates that are available that we referred to before, referral template, colonoscopy report and the GP report. And the assessors to the national standards have also had additional training. So this is a video that was developed by the Commission for the assessors, and the Commission have kindly said that they will share this with everyone on today. So this will be put through the chat box. So if you'd like to look there, you can actually get access to this video link. It's always a good idea for you to see what the assessors have seen so that you know what they're looking for in your facility. And this is probably one of the best exciting news that I've seen, that they're developing Aboriginal and Torres Strait Islander specific resources. They're currently in development. They've almost got the fact sheet ready and there's a consumer video coming as well. So thank you so much for your time. We've got all the experts on the line now. So I'll go over to Mel and see if we've had any questions, Mel. Thank you.
Thanks, Amanda. That was great. I'll just wait for the others to come back and put their cameras on. In the meantime, I'll just give you a little poll for all you attendees just to get some feedback on today's webinar. So you should see that pop up on your screen now if you can just answer those questions. And then we've got some questions from the audience.
Great.
Lots of voting happening, so that's good. Just encourage you all to answer those questions. Okay, I might leave that poll there while we take some questions. So we have a few. In private facilities, how do we evidence the informed consent process for patients prior to commencement of the bowel prep when the VMO consults with the patient in their rooms, or conversely for direct access patients who will not meet the proceduralist prior to their procedure?
We had a conversation about this before the seminar. Did you want to answer this, Anne?
I'm happy to. So when the VMO does it in their rooms, it's not really the responsibility of the health service to ensure that, because it's occurred outside. I mean, going forward, when we have accreditation for primary care and care that occurs outside hospitals, i.e. when we have accreditation right across the health system, that'll be wonderful. We'll have a different mechanism. But it's certainly not the responsibility of the health service to interrogate what conversation the VMO and patient had. But it's good practice, of course, to ensure that there is some written documentation that that did occur. So that's why we have consent forms that we check before people have the procedure. So with the direct access patient, I think there's two things. There's a direct access patient and then there's an open access patient. So the direct access model in my mind is where the patient is referred up to a health system. It's a bit like the New South Wales Cancer Council has done, and the patient's referrals looked at, and then straightforward patients are contacted by a nurse who's trained in endoscopy and who goes through the process, who talks to the patient about the risks and benefits, and talks to them about the prep. And so the patient's informed and prepared, and medications are looked at and checked, and their medical history is checked to see whether in fact they do need a colonoscopy, or they've just had one a year ago in the system, and so the GP might not know about that. And so there's a whole lot of pre-procedural stuff being done that all makes sense to improve safety and quality. Open access, where the patient just turns up not having been seen by anybody until a procedure on the day, I have great concerns about, in terms of how on earth do you do informed consent? The patient's just taken the time off, just taken their prep, has just turned up. It's a bit late then to have a conversation about your symptoms and whether you need a colonoscopy or not. So I think that is an issue for clinicians to think about. Now, if you're in a situation where you've trained up your GPs to be able to discuss the risks and benefits of colonoscopy and be right across it and be able to inform the patient, that's something. But I think if it's just a case of the patient being referred up on the principle that they can have an informed discussion on the day, I'm not sure that really is informed consent. So I don't know what people are doing about that. I can see that direct access has lots going for it. I think there is something to be said for seeing people and having a chat about the pros and cons and the risks and benefits of a procedure to them, not the risks and benefits of procedure, but the risks to them and the benefits to them, because it changes. A 20-year-old and an 80-year-old are very different things. But I can also see how in the public sector we have such a pressure on resources that an outpatient face-to-face consultation is resource intensive, and a direct access process where a trained up nurse can ring the patient is a great option. So I'll leave it there. Amanda, you might like to add something, but I think at the end of the day,
I think that's our trouble, Anne, is the open access in a lot of the private settings, I think. So I think you answered that beautifully. Thank you, Mel.
Thank you. Now, Lisa has put a link. I assume you other people can see that link to some colonoscopy guidelines from the New South Wales ACI. Lisa's asking, should these be used in New South Wales rather than the Cancer Council document? I assume she means the Commission document.
No, there's the NHMRC guidelines for colonoscopy for screening and surveillance, which Amanda put up. And I think the ACI is just consistent with it. I haven't, it's a while since I've looked at all that, but we've tried to get consistency across the system. I'd be interested in anyone's comment that there's not consistency across the system.
The ACI did share those with us. They're more around triaging the patients as they come through for colonoscopy into the
Yes.
That's what they're, so you actually would need to use both. Surveillance, they're separate, they're different guidelines.
Oh, thanks, Siobhan.
Yeah.
I do think when you've got a high pressure system, as the public sector does, there's a lot of opportunity to triage patients based on risk and likelihood of a positive finding at colonoscopy. So an 80-year-old with PR bleeding is much more likely to have bowel cancer than a 20-year-old with abdominal pain. So yes, you're right that those ACI guidelines are really drilling down to that. How, if you've got an X amount of space, how should you use that space wisely to give the maximum benefit to the community? I'd forgotten that. Sorry.
I might just add, sorry, Mel, before you jump ahead with another question, I might just add, I answered one of the questions, sorry, and I forgot that it actually
takes it away. No, it's here as well.
There was a question about
can we add the video to their website? And you absolutely can. Even I was going to answer that one. So
Yeah,
You
so
absolutely can. And there's a couple of questions about will you get the PowerPoint? The recording of the webinar will be sent to all registrants. So
yeah. So two things, the recording. So the link I provided was the general colonoscopy clinical care standard link. But if you go into that, you can navigate to our consumer page, our clinician pages, and all our resources are there. And there's a lot on there. So I didn't send you the direct link to the video or to the resources, because there's a whole lot of information around the standard and our resources. But if you, it's pretty straightforward to follow. But if you go into the colonoscopy clinical care standard webpage, on the right hand side, you'll see a list saying information for clinicians, information for consumers. And in those pages, there's additional resources, but also all the resources and the templates that we've developed. I hope it's straightforward enough. And the videos are all there as well.
Great.
And share, absolutely, you're very welcome to share links from your own organization's websites to ours.
Super. Okay, another question. I have a surgeon that has been advised that we as a hospital have to provide him the latest colonoscopes available for the best pictures diagnostic probabilities. Our older scopes are still in HD. They're just not the latest available. I've approached GSA and asked this question to see if true, but no clear answer was given. Can anyone give me some direction on this, as this will be an expensive exercise for the hospital if true?
There's no evidence that that's true. Nobody is actually requiring that.
Standard does that, that's out of scope. It doesn't cover anything.
Yeah.
Yes.
Nice try though, good try.
The facility has a responsibility to provide reasonable equipment responsible for safety and quality. The latest is not necessarily what's required. There's nothing in the national standards that actually directs facilities to always buy the latest. Yeah.
Great. In regards to discharge, if the patient is unable to receive the verbal or written information normally passed on to the patient, for example, for a cognition deficit, is it specified that this information must go to another person, for example, the next of kin, if available?
Well, we didn't write it into the standard, but it's a very good thought. Common sense would say that you'd want to tell somebody who is the person responsible in that setting, because they're the person who actually, if they're cognitively impaired and unable to give consent, and somebody else, because of an emergency or whatever, gave consent, that person should be responsible. But it also makes sense that somebody who's cognitively impaired but able to give consent may not necessarily, not like most people post a procedure, don't necessarily remember stuff. So it makes common sense would say you should make sure that you've given the best communication and information you can. Amanda, is there anything you want to add?
No, that would be my response too, and have to be on an individual case, of course, where they come from and who's picking them up, who's looking after them afterwards. So definitely.
Good practice to prevail.
Great. Siobhan, there's a question around somebody looking on the safety and quality page for the clinical care standard but can't see the resources. Are you able to just pop that link in the chat? Tina's after that link.
I will. I'll go.
Thank you. Another question. So what will an assessor want to see during survey?
Well, an assessor will want to see a gap analysis, if you like. So an assessor should be checking your compliance to all of those statements and seeing which parts are your responsibility. An assessor should also be asking your clinicians, your relevant clinicians, if they've been provided a copy of the standard. And because it's an advisory, that's what we were saying at the start, because it's an advisory, they can't not do it. So you need to show compliance to it, basically. So what we suggest where I work is that you do a quick little gap analysis on a bit of paper, whack all your evidence together, or electronically, just to make it easier if you've got time to do that.
Great, thank you. There's just been a clarification, and that question you answered just a moment ago regarding the direct access. The person said they actually meant open access, that's an issue for them.
Yeah.
I think that just clinicians need to think through the service they're providing and does it meet the definition of informed consent.
Great. A question around auditing. Is an audit annually, for example, all patients who undergo a colonoscopy for the month of October, a strong enough method to ensure we are following guidelines?
Is that for the indicators? I'm not quite sure. If it's for the accreditation, yes, but you'd also need to do the indicators as well, and that wouldn't just be 1 month's worth of patients. So I'm not entirely sure of the question, sorry.
Okay, we'll wait. It's from Julie. If Julie's there and would like to clarify, I'll leave that one open. Another one, what happens if a VMO refuses to log their number of colonoscopies re-EPP process?
Well, that's for the credentialing committee. The standard now requires that facilities only credential people for appointment to the hospital and for practice in endoscopy and colonoscopy if they have met the standard. So it is important that everybody does it. I can understand that people who have trained before CCT-RGE existed may be anxious that they might be not up to speed, etc. But I think one of the important things that quality managers can do is to allay unfounded anxieties. So the re-credentialing process is accompanied by a whole lot of education and training tools so that people can practice colonoscopy safely and become educated in all the new techniques through a whole lot of mechanisms. I think at the end of the day, the important thing is that we can be confident that everybody who is doing colonoscopy in Australia is doing it to a high standard. So the aim of the game is not to exclude people, but to bring people on board by encouraging them to, if they've got out of, haven't kept up with the latest in technology, cold smearing, hot, all sorts of stuff, lifting, all that sort of stuff, that they actually do all that. But at the end of the day, it's no longer makes sense to have people who aren't credentialed, because colonoscopy, anyone who's been in the game long enough knows, the whole thing about polyp detection and polyp management has changed markedly over time. We know more about how to remove polyps. We know much more about when people should come back for surveillance. So there's just no logic in having people who don't want to play the game in the modern world. So I think that what would happen is, quite seriously, the credentialing committee or at the recommendation of the credentialing committee, there'll be a recommendation made that that person either did decide to log or decided to do something else.
Julie's just clarified in relation to that previous question that it is in regard to for the indicators.
Oh, the indicators, my understanding is it needs to be everybody.
It has to be everybody.
Yeah.
A facility can't know how safe it is and can't assure the public that it's safe and high quality if it doesn't know exactly what's going on in its facility. It's no good saying, well, we've got 3 very good people out of 6. It needs to know that every day of the year you have high quality going through your unit. You know what everyone's doing. You know what the unit's monthly outcomes are in terms of adenoma detection, in terms of polyp, in terms of adequate bowel prep, all those sorts of indicators. It's about the facility knowing how good it is, which is different to people when they get recertified. They're actually just seeing if they meet the bar, and therefore are they good enough to continue doing colonoscopy. But at the end of the day, this is all about the facility knowing it's actually running a pretty tip-top show.
Great. A couple of people asking, is there a gap analysis template on the website?
No, we don't have a gap analysis template on the website. Amanda, do you have one that you could share with the group?
Look, I would be happy to. We just do usually just a simple spreadsheet, but very happy to. Yeah, why not? Would love to.
Great idea. If you want, you could share that with us. We could look at it and consider putting it on our website as well.
Sure.
Great. How do we record the VMO number of scopes? Is that the site's responsibility or the VMO?
Is this for recertification or is this for accreditation? I mean, you must have, I presume it's for recertification for the individual. The individual does their work and brings it back, their certificate back to the organisation when it applies for to work in that facility. So that's the consultant's business. If accreditation, well, the system should know how many procedures are occurring across the facility.
The person's clarified it's for recertification.
Oh, so for recertification, that's the responsibility lies with the clinician, and the hospital can decide what information it wants. Because remember, a lot of people practice in a number of facilities, so their recertifications based on consecutive cases. So they might, in 50 cases, they might have done a list at one hospital A, then hospital B, then hospital C. That will be their recertification, will be consecutive cases outside so it's outside the orbit of the one hospital.
Great. Question from Tracy, who's the NUM at the JFPH. With our open access, the patient's referral is viewed by the gastroenterologist who has agreed to undertake these patients, and the GP is contacted for further information on the patient's history, and the gastroenterologist of the day makes either an appointment or a telehealth appointment if deemed appropriate to glean informed consent.
That's sounding like a better idea than just
Okay.
turn up on the day and have a chat.
Great. Similar to the consent question that you responded to, Anne, what about patients who are provided the bowel prep by the VMO? Is this a similar response that it would not be the responsibility of the organisation? If so, is that sufficient for accreditation purposes?
So we've said if the organisation takes responsibility for providing the bowel prep, it's engaged in that part of the process. If all of that occurs outside in the VMO's rooms, then that's outside the realm of responsibility for the organisation. That's how it is intended. Does that make sense to Amanda? Does that make sense to you?
Absolutely. Yes. Yes. So preferably for organisations, if it's done at the VMO rooms, you don't need to worry about it. Yeah.
It's not your responsibility, it's the VMO's responsibility.
Great. With patients that are referred from the public hospital to a private hospital for the completion of the colonoscopy under a different VMO, what information should be obtained from the public hospital? Information provided to the consumer and consent process that may have occurred at the public and/or occur on the day of the procedure with the new VMO assigned this list. How should this be managed?
Do you want to answer that, Anne?
Yeah, I'm just going to read through. It's very.
Yes, it is.
I think that the facility has to be, well, both the clinician and the facility has to be adequately satisfied that the patient is informed. So what information should be obtained from the public hospital information provided to the consumer consent process that may have occurred. Well, I think this would be a case where the private, it's a bit like coming from it's the same category as coming from the VMO's rooms. You're coming from outside the facility. So the facility has limited responsibility, but the consultant has responsibility for making sure that they understand why the patient needs a procedure and whether the patient's informed, etc. But I don't think that the private hospital, as it hasn't had anything to do with the referral from outside. I mean, it'd be the same as referral from anywhere outside. I might need to take that on notice and look at it more closely, but that's how I read it at the moment. If that makes sense. Amanda, what are your thoughts?
Well, my thoughts are, whilst I agree with that, I'd also like to see some due diligence and to just ask the public hospital what's been done with them, get their policies and procedures, and is the public hospital giving them their prep before they come over? In which case, do you know that they've been consented properly? I think it's worthwhile asking the question before there's a problem, to be honest.
I think that in the interest of
on a regular basis.
in the interest of safety and quality, I think that's best practice in terms of accreditation. I suppose we haven't gone down to that level of detail, but I think I absolutely agree with you, Amanda. Best practice would say you try and know as much about the patient and get as much of their history as possible.
Yeah.
Thank you. Does the organisation need to show evidence of clinical indicator data capture and monitoring? Is this a monthly requirement or annual review?
Sorry, for a month, sorry, with the clinical indicators, is that for accreditation? I'm not sure again of the question.
Let's call it for accreditation.
For accreditation, then the answer is yes. Yes, you need to be measuring the output of the standards. So absolutely, yes.
And it's not specified whether it's to be monitored monthly or annually. It really depends on how it's set up at the facility.
I think at the end of the day, what we're trying to do is really drive safety and quality across the system. And what we've done is already created an environment where facilities which were actually having handwritten reports have gone to electronic systems and much better quality reports. Systems which didn't look at any sort of review of the outcome data are getting better at it. But really, at the end of the day, where you'd want to be is living in a country where we had fantastic data sets, which were largely automated. You would hope that at the end of the day, you'd be able to know all the time how well your endoscopy system functions. What happens with accreditation early on is different to where we want to be in 5 years. So I'm not sure, and Amanda's the expert in this in terms of accreditation, but I can't imagine that accreditation at this stage would want you to be able to show your data for every moment of the day. But you do want to be showing that you're actually trying to improve and you actually are at a reasonable benchmark now in terms of your monitoring your data. But it's a question of what do you think a high functioning, high quality unit should look like, and are you trying to get there? I'll hand it over to you, Amanda.
Yeah, look, I understand now. And the thing is to be going down that path, to be looking at what processes you've got and how you're reviewing your incidents and all that sort of stuff. So remember too, with the standard, there's a lot of peer review written into it as well, as there should be for not just colonoscopy. So I think the idea as from an accreditation point of view is that you understand what is required and you're working towards it.
Because in the long term, we're trying to have a system that doesn't need accreditation, that it actually accredits it all the time. It looks at how well am I doing every day. It says, how well am I doing? It doesn't sort of say, oh gosh, we've got accreditors coming. We must look at how well we're doing. If you look at the long-term goal, it should be that everybody wants to know every day how well it's doing, not just before the accreditors come. So I think that's sort of the right lens to have. And hopefully with the work we're doing with the endoscopy companies, we can actually automate a lot of data so that it can actually be regularly fed back to clinicians so that they can improve or maintain a high standard. And consumers are going to get information that knows that consistently there's high standard.
Great. Is the colonoscopy report template to be given to the patient or to the GP? If it's meant for the patient, it appears complicated and not health literacy focused.
We did all these things to support the system. A lot of people out there have endoscopy reporting systems, referral templates or follow-up letters templates. It's designed not to be a mandated thing, but if there's a gap, we don't want everybody using up energy reinventing the wheel. So everything has been provided freely for people if you want to use it And if you want to use it and adjust it and modify it, that's fine. We just want to make life easy for everybody and help everybody improve their system. And I'll take on board that if it's not user-friendly. I don't know exactly which form you're referring to, but it may well be that we haven't made it user-friendly. We've certainly put in place an endoscopy reporting form for those units that didn't have electronic systems for reporting, to point out that there are a whole lot of things that should be in a report, like the quality of bowel prep, like how far did, like what you did.
Great. Is there a standard way of collecting the proportion of SSA or SSP detected? Our service uses a mix of public and private pathology services. Private results are not visible in the public system.
Well, this is the challenging thing that we are doing a lot of work on this, but at the moment, in this country, as far as I can tell, most systems aren't integrated. So there aren't too many units to integrate. Siobhan has been doing a lot of work to try and improve it. I think it'll be a long time before we have an automated system. That's the long-term goal. Is there anything you want to say, Siobhan?
No, just to let people know that we are working with Endobase and Provation, which are the main endoscopy information systems that are being used currently. And they know there's a gap there in their systems in relation to interfacing with pathology systems and getting those results automatically back into the system and therefore then uploading into their reports. So there is work happening. Of course, the colonoscopy clinical care standard has shed a bit of light on this. So there's a bit of more of a push from those information system vendors to kind of ensure that this is integrated a bit more. But of course, we know that in the digital health ecosystem that we currently live in Australia, there's a lot of work happening in this space as well. So it's not something that's resolved now, but hopefully in a few years that this is something that would automatically happen in the background, and we won't even need to focus on this. So I know it's not the answer you're looking for, but there is work happening. People are aware of those issues.
It's a shame that when we developed automated systems, we didn't think about, well, why do we want the data? And we connected up the link, did the linkage then. But anyway, we realised we do want to know what the data shows, and we're working, as Siobhan said.
Great. Where does antiplatelet or anticoagulation risk management sit in the Commission's view of adequate preparation? I'm aware of sentinel events around this issue and organisations without a standardised guideline for this issue, which is well regarded elsewhere.
You've raised a really critical point. Adverse events with anticoagulants, adverse events with the new diabetic drugs are really important issues. It wasn't a separate policy statement, but it does go to the intent of the standard in terms of trying to lift the bar with better referral letters from GPs. And you'll notice in the template, there's, we want to ask what people's medications are, so those sorts of things don't get missed. We really want to promote a discussion between the patient and the consultant, informed consent, to ensure that when we talk about informed consent, it doesn't just mean that patients informed about the procedure. It also means that the consultant is informed about the patient's risk profile, i.e. they're on anticoagulants or they need to think about stopping them. That changes the whole risk profile for the patient. They're on diabetic drugs or whatever. That's why the standard so emphasises the importance of informed consent, because you've just highlighted colonoscopy is not a without risk procedure. People should be informed of what the benefits to them are, what the risks to them are, and how those risks can be mitigated and the benefits maximised. So it's a really good point. It's not a separate quality statement, but it certainly underpins many of the quality statements.
Great. In terms of the clinical indicator, we have issues with resourcing to be able to review the histological findings to confirm the sessile serrated adenoma detection rate. How have organisations addressed how they collect the indicator data?
We haven't talked to the College of Pathology about this, but clearly it's an emerging thing. Cephalosporin adenomas weren't talked about years ago. Part of it is training up the pathology workforce to make sure that they're skilled at recognising it. And I suspect across the country there's varying familiarity with SSAs and the importance of identifying SSAs. It's work to be done. I don't know that there's any answer except to ensure that your pathologists know about the clinical care standards and know the importance of correctly identifying the histopathology. But it's a good talk. We might talk to the College of Pathologists.
Great.
Maybe put something out to actually, or do some education if they think there's a gap.
Thank you. In terms of the clinical indicator, no, that's the one I've just asked. This may have been answered. If a consumer is consented in their VMO rooms and then presents to the hospital to pick up their PrEP kit, does the hospital need to have consent proof at point of PrEP kit pickup?
It's an odd scenario we hadn't thought of. Well, if the consultant's done the consent process, I think you could say that the consultant, that you'd have to have, I'd have to think that through why you'd have a situation where the patient goes to the room, goes to the hospital to pick up their PrEP.
Does that happen often?
I think that does happen, especially in places where you may have rooms at the hospital and they'll go to a particular ward sometimes to pick up the PrEP or a source. So I think that happen quite a bit, yeah.
Well, then then the facility, if the facility is providing the rooms, etc., then the facility is responsible. Because the whole thing's occurring on the roof of the facility, isn't it?
Yeah, and look, again, I think if I was the one handing out the PrEP, again, I think it's just good practice to say, to check if the patient has been told the pros and cons, and if they have been told about that before you hand over the PrEP. I think even if you could argue that the VMO should have done it, I still think we've got a duty of care to make sure that they've been told. So however you want to do that, it's a quick process.
I agree with that.
Yeah, that person's just clarified to say yes about being informed before taking the PrEP.
Yeah, then that's fine. I think that's reasonable, don't you, Anne? You've taken reasonable steps, yeah.
Yes.
And I think by doing that gap analysis, Amanda, building on what you've said, you know, they're the sort of things that will be highlighted. What are things that are currently happening within our organisation that need to be addressed? And, you know, they're the sort of things that will pop up.
Yeah. And of course, putting whatever gaps you've got on your action plan and taking it to your appropriate committees to be working on. You can still go into accreditation with gaps if you are actively working on what's going on, providing that you are working on it and it's not an unsafe environment. I think things like that. And that's why you do a gap analysis, to see what your processes are. And it's not just for accreditation, like we said, it's about, you know, preventing a serious issue for the patients.
A query: are the colonoscopy clinical care standards endorsed by RACS, the Royal Australian College of Surgeons, to raise accountability and awareness of surgeons during the implementation process?
Yes, they're endorsed by the College of Anaesthetists, the College of Surgeons, the College of Rural and Remote Medicine, the Colorectal Society of Australia, GENCA, GISA, Cancer Council, College of Physicians, Day Hospitals Australia, and Lid Syndrome Australia.
And also they've had their own webinars as well. So I think that's really good for quality managers to know that GPs have had a session like this, as well as proceduralists, as well as GENCA did one for nurses, for theatre nurses. So that was really good too. So, and that's another reason why it's really good. So everyone's been informed, the video for the patients. So like I said, the care standard goes across all three key stakeholder sets. And so that's what you want. They have been informed.
Dr. Ian Skinner, who was the co-chair of our topic working group for the colonoscopy clinical care standard, he presented to the colonoscopists, and we had a huge turnout to that webinar. That was one of the first ones we did, the second one I think we did. And so, yeah, we've been continuously communicating and educating clinicians about this standard through the webinars and through our resources. And the RACS website, for example, has all the resources links on their website. So we're writing to the Royal College of Physicians and the GPs as well to put all our resources up on their website too, and links to our website. So it's been a lot of work trying to communicate this standard out to the different stakeholders, but it's happening, and yeah, you'll start to see a bit more information on those websites.
The recertification is currently run by GSA, just because GSA started off, but there is currently work in the background, so that there will be a conjoint committee of College of Physicians, College of Surgeons, College of, and the GE Society, just like certification is. It's just taking longer. We thought by the time we got to the end of the standards, that would have happened, but it's still in the pipeline. And so surgeons should feel reassured that just like certification, it's a tripartite group represented by the key players.
There's a couple more around consent and picking up the bowel prep. So one person says, our hospital posts out the bowel prep information but expects the patient to pick up their prep from the local pharmacy themselves. Is that okay?
As long as they're informing patients about bowel prep and how to take it, and etc. If they're taking responsibility for that, I would think they should be making sure that they be confident that they're actually informing the patients of how to do it well. That's what we're trying to do with the standard.
Working in a private hospital which has a hospital pharmacy, if the VMO is sending the patient to the pharmacy to collect the prep, are there implications to the hospital regarding verifying consent?
I would say technically it also depends upon if you own the pharmacy as well. The hospital owns a pharmacy, but again, in my opinion, because it's happening under your roof, I think you need to do that gap analysis and see what's going on. So it's all about protecting our patients. So ask them, because as far as I'm concerned, if I'm aware that there's a problem and I don't do anything, I'm responsible for it. So I would be asking the question to the pharmacy about what's going on, and just double checking with your VMOs if they're consenting prior. Look, I assume they are, but I would still just do that work just to follow up and put it down in your gap analysis as well.
Working in a day procedure unit, we ring and check all patients have lifts and responsible adult to care for them post-procedure, along with other medical history, bowel prep, etc. On occasions, people will attend and their post-procedure carer is not available, or for those people who refuse to arrange a responsible adult to stay with them. How do we progress or deal with these situations when we have stressed the importance of this care and then the patient decides it to be unnecessary or circumstances beyond their control on the day?
Well, I think this is an important issue, and I certainly work with an anaesthetist who won't anaesthetise somebody, give sedation to a person who hasn't got a carer, who takes their job very seriously. And I'd be interested in how many anaesthetists would be prepared to do a procedure knowing that the person hasn't got anybody to take them home and it's going to be discharged. Are they going to make them discharge against medical advice? It's an interesting situation. If you believe it as an anaesthetist that it's the only safe way to do it is for a person who's had sedation, have someone take them home, and if they're elderly, have someone be with them overnight, then should you be doing a procedure on them? I'd be taking it back to your anaesthetists and saying, would your society stand by you if something happened? Do you think it's safe? At the end of the day, this is a really important clinical question. Are you confident that you're providing safe care? An 80-year-old going home in the bus or whatever. You're trapped by people who say yes before a procedure, yes, if the person will take me home, and then afterwards they don't have anybody. and you have to spend a lot of time trying to find somebody to take them home, and that's unfortunate. But before the procedure, it's a different ethical issue. So I'd be interested to hear other people's views on the subject. I know my anaesthetist view on the subject.
It's something that can happen not just for colonoscopy, for any day procedure. And I've been in the situation where it's happened, you know, you're just stuck with them in the recovery room. So I think it's part of having it on your risk register for your facility and having plans in place of escalation of these issues when they come. So I think the facility needs a plan about who you contact, et cetera, and maybe risk rate the actual individual and what you're going to do. Obviously, if you have overnight facilities, that would be good to offer them an overnight bed if you can. And if not, then you're going to need something to make sure that that person's looked after afterwards. Yeah, so I would be looking at it before it happens, yeah.
It's an excellent approach, a very system-based approach.
Great, that's the end of the questions. I would just like to share with you the results of our poll we did, which we had great response to. So 89% of attendees, and we had around 130 attendees online, 89% have either completed or have underway their gap analysis.
Great.
I knew you'd be pleased with that one, Amanda.
Yeah, fantastic.
Of those, around 30% said that there has been some resistance from clinicians to that.
Well, that would be higher, so that's really good.
Okay, good. 46% have developed protocols for recredentialing, and there was another 45% unsure. So maybe that figure is higher as well. You'll be pleased to know 96% found today's webinar useful.
Well,
And
that's lucky, isn't it?
and 91% were aware of the resources available.
That's great. That's good that the information's getting out there then.
Yeah.
So I just wanted to make sure too that people were aware that you can contact the Commission. You can contact them on their email if you have any further questions, because sticky things do come up, and even when we think we've understood something, you know, a curveball can come, like the patient that we can't send home, etc. So always reach out for assistance if you need.
Yep. Or if you've got recommendations as to what we should do if we've got gaps.
Just one final question regarding the gap analysis template, Amanda. Someone's just asked, where will that be shared? Will you provide it to those that have attended, or I guess it might go to the Commission eventually?
I'll ask Siobhan that. Where will we send that, Siobhan?
I think if you send me your template, we'll get a list of everybody who attended today,
yeah,
and we can email that directly to everybody, because we won't post it. We get it on our website. There's a process.
Yeah.
Best if we just email that directly to those who've attended today, and then if it's something that we think would be useful on our website as a resource, then we'll do some work with it to put it up on our website as a permanent.
There were certainly lots of people very happy when you said you'd develop that template, Amanda. So I think
that's a verb, not a statement. We will develop a template.
So,
great.
So what we'll do post the webinar is in the next week or so, when we get the video, we'll have this video we're recording it, and we'll have it available, and we'll put it on our website, but we'll also email all the attendees the link to the webinar recording, and we'll attach the template also to that. And Anne Marr does all that for us from the Commission, so won't forget to do that.
Great, that's all of our questions. We're just getting some nice positive feedback at the moment. So over to you, Anne Duggan.
Always be really rude and interrupt just all the people online as well. All the other templates and standards and fact sheets that come out from the Commission, there's a lot of work going on next year. So for example, the medication section of the Commission, there's a lot of work going on next year for more webinars and training coming from the Commission. So hang tight and see what else comes out, because they're working really hard to give us lots of resources and tools. Thanks so much.
I'd like to thank Amanda very much for doing the presentation today. It's been very informative and I've learned a lot. I like your mindset of a quality manager. I'd like to thank not only Amanda though, but for the audience, because you're all busily, wherever you work, contributing to making the colonoscopy clinical standard a reality and ensuring that no matter where people live in Australia, going forward, they will have high quality colonoscopies, which we know colonoscopy is really important, particularly in terms of preventing bowel cancer. So you're getting this in place requires everybody doing their bit. You're doing a great bit, and I would hope that when we look at the data in a few years' time, we'll see even bigger drops in bowel cancer across Australia, or moves to earlier cancers rather than late cancers. So I'd like to thank the audience, and of course, thank Amanda, and of course, Mel and Siobhan and Anne for all the hard work you all do. So thank you, everybody, on behalf of the Commission. Back
Thank
to
you, as well. Thank you, everyone.